Welcome back to the deep dive. Today, we are immediately plunging into one of the most elegant yet, well, precarious balancing acts your body performs, managing water and salt. And the key player here, it's a humble signaling molecule called ADH, or antidiuretic hormone. When this system goes wrong, though, it creates two dramatic, perfectly opposing disorders: diabetes insipidus, DI, and the syndrome of inappropriate antidiuretic hormone secretion, SIADH. It really is the ultimate contrast, like too little versus too much. And for you, our mission today is to make sense of this mirror image.
Yeah, and what's fascinating here, and maybe the first big takeaway, is that both of these conditions, they represent a kind of catastrophic failure of the body's usual checks and balances, homeostasis.
Right.
Our sources really emphasize that the body relies on this constant, dynamic, negative feedback loop to regulate water balance.
Okay.
Think of it like a thermostat, maybe, for your internal water levels. If your blood gets too concentrated, too salty, ADH should kick in to save water.
Makes sense.
And if your blood is too dilute, ADH should, shut down so you can pee out the excess water.
So DI and SIADH, that thermostat is broken.
Fundamentally broken, exactly. It's either stuck on full blast water saving mode, which is SIADH, or full blast water dumping mode, which is DI.
That failure of feedback, that's really the key idea then.
It underpins everything.
Got it. So our goal for this deep dive is to clearly unpack those opposing causes, their, dramatically different clinical pictures, and the absolutely critical but totally contrasting management strategies you need for these patients. Okay, let's start with DI then. What happens when that ADH signal is too weak, or maybe missing entirely? Is it always about the brain not making the hormone, or are there other ways this happens?
That's a really important distinction. DI, the too little ADH situation, it's characterized by massive uncontrolled water loss, just pouring out fluid. And yeah, there are two main ways this happens. First is central DI. This is where the pituitary gland or the hypothalamus, they've been damaged somehow, maybe trauma, maybe surgery, maybe a tumor, and they just stop producing or releasing ADH.
Okay, so the source is the problem there.
Exactly. But the second way, which is critically different, is nephrogenic DI.
Nephrogenic meaning the kidney.
Precisely. Here, the pituitary is actually doing its job. It's releasing ADH. But the kidneys, specifically the tubules down there, they're insensitive to it. They just ignore the signal.
Wow. So the message is sent but not received.
You got it. But in both cases, the result is the same. The kidneys dump huge volumes of water. This leads to the blood getting concentrated, high sodium, that's hypernatremia.
And our sources mention 4 subtypes: central, nephrogenic.
Yeah, dipsogenic, which is more about excessive thirst originating potentially in the hypothalamus, and gestational DI, which is temporary during pregnancy.
Okay, now let's flip that.
Yeah.
Contrast it immediately with SIADH.
Right. Here you've got the exact opposite problem: excess ADH secretion. And it's inappropriate excess. It happens even when the plasma is dilute, when the body should be saying, stop, no more ADH.
So the off switch is broken.
The off switch is completely broken. The body should be screaming at the pituitary to shut down ADH production, but it just keeps flowing.
That sounds like internal flooding, almost.
Yeah.
What's the direct result of all that extra ADH?
It is. You get relentless water retention. All that retained water dilutes the blood, leading directly to hyponatremia, so low serum sodium.
Low sodium?
Yeah. And because the body is hoarding every single drop of fluid it can, the little bit of urine that is produced ends up being extremely concentrated. It's a total reversal of the DI patient's chemistry.
What's really surprising, looking at the sources, are the risk factors. You show these aren't just like isolated brain problems.
Not at all.
For DI, okay, we often think neurological causes: head trauma, brain surgery, tumors. That makes sense. But there's a strong medication link too, right?
Absolutely. Lithium, which is used a lot in psychiatry, is a classic cause of nephrogenic DI. And the antibiotic dimeclocycline is another one.
Okay. But the SIADH risks seem even broader, more systemic.
They really are. I mean, yes, CNS disorders, stroke, trauma, tumors are frequent culprits, just like with central DI in some cases. But SIADH has this huge connection to pulmonary issues.
Lungs.
Lungs. We're talking pneumonia, tuberculosis, and maybe most notoriously small cell lung cancer.
Wait, hang on. Small cell lung cancer. That's nowhere near the pituitary. How does a lung tumor cause ADH problems?
It's a really classic example of something called ectopic hormone production.
Ectopic, meaning like out of place.
Exactly. The cancer cells themselves, the lung cancer cells, can actually start manufacturing and secreting ADH. They create their own ADH, completely bypassing all the body's normal regulatory feedback loops.
So the tumor becomes its own little ADH factory.
An unregulated.
An unregulated ADH factory. Precisely. It just pumps it out. Wow. Okay. And then there's the medication list for SIADH, which really drives home how, I guess, delicate this whole ADH system is.
It really is sensitive. Beyond certain antipsychotics like phenothiazines, tricyclic antidepressants, and some chemo drugs like vincristine, the source specifically calls out thiazide diuretics, which we'll come back to because it's weird, and even nicotine.
Nicotine.
Like
from smoking.
Yeah. It can stimulate ADH release inappropriately in some people. It just highlights how many different things can nudge the system off balance. Now, when we look at how these patients actually present the clinical picture, the symptoms are so dramatically opposed, they practically define each other by contrast.
Yeah.
In DI, the primary terrifying driver is that uncontrollable water loss. Extreme polyuria.
Polyuria, meaning lots of urine. How much are we talking?
Well, to put it in perspective for you, our source really stresses the sheer quantity. A patient can put out up to 20 liters of urine per day.
20 liters? That's staggering. A normal person is maybe, what, 1 or 2?
Exactly. 1 to 2 liters is typical. 20 liters means waking up constantly, every hour maybe, running to the bathroom, and being intensely, overwhelmingly thirsty. That's polydipsia.
Just can't get enough water.
Never. And this leads straight to classic dehydration signs. Dry mouth, dry mucous membranes, poor skin turgor.
And the sodium level, the high sodium, the hypernatremia that causes its own problems, right?
These are huge problems because it dehydrates the brain cells. You start seeing confusion, irritability, and if it gets severe enough, seizures or even coma, the urgency is absolutely there.
Okay, so that's DI like desert inside. Now, flip to the SIADH patient. They're dealing with the total opposite.
The exact opposite experience, water retention. So they have very low urine output, often less than, say, 400 milliliters a day.
Barely anything.
Hardly anything. And here's a really counterintuitive point our sources highlight. They often present with weight gain, but without obvious swelling, without that peripheral edema, at least initially.
Wait, how does that work? If they're retaining water, shouldn't they be puffy? Swollen ankles and things?
You'd think so, right? But it's critical. In SIADH, the fluid is retained more centrally, kind of diluting the entire blood volume very quickly. This actually suppresses other systems, like the renin-angiotensin system, that would normally contribute to edema.
Ah, okay.
Because the fluid is diluted throughout the vascular space, not just leaking into the tissues initially, you don't typically see that classic pitting edema until the condition is maybe quite advanced or severe.
Got it. So their symptoms are driven more by the low sodium, the hyponatremia.
Absolutely. That dominates the picture. It might start subtly, nausea, vomiting, maybe a headache, feeling generally unwell. But as that sodium level drops further, the neurological stakes escalate dramatically. Severe confusion, muscle weakness, twitching, and again, seizures.
Seizures seem to be a risk on both ends then, just from opposite problems.
Exactly. Opposite electrolyte imbalances hitting the same critical organ, the brain.
So the complications really reflect these root issues. DI, if unmanaged.
You're looking at severe dehydration, potentially leading to hypovolemic shock. The blood volume just drops too low to sustain circulation.
Right.
And the brain is constantly at risk from that severe hypernatremia causing cellular dehydration.
And for SIADH, the big danger is the opposite. Too much water.
Too much water, specifically causing water to shift into brain cells. This results in cerebral edema brain swelling.
Oh, wow.
That swelling, combined with the critically low sodium levels, is what triggers those life-threatening seizures and coma. So yeah, both conditions are rapid routes to a neurological crisis, just taking completely opposite paths to get there.
Okay, so moving on to diagnosis. The lab work is really where that mirror image becomes, well, indisputable. As a clinician, you're looking for completely opposite numbers in the blood, the serum, and in the urine.
Right. Let's nail down the DI labs first. What are the key numerical fingerprints we're looking for in the blood?
In DI, remember, the blood is concentrated because of all the water loss. So you'll see high sodium hypernatremia and high serum osmolality, usually greater than 295 milliosmoles per kilogram. High in concentrated blood. What about the urine?
The urine is the opposite, massively dilute. It's reflecting that water just pouring through. So you see a very low urine osmolality, typically less than 300 millismoles per kilogram, sometimes much lower.
Okay, high blood concentration, low urine concentration. Makes sense. And there's a specific test.
Yeah, to really confirm central DI or differentiate it sometimes, they perform the fluid deprivation test. Basically, you withhold fluids for 8 to 12 hours and watch carefully. You see if the body can concentrate urine on its own when dehydrated. If it can't, and then responds to synthetic ADH, that points strongly to central DI.
Got it. Okay, so the SIADH numbers should be exactly the inverse of that, right?
Precisely. Mirror image. The blood is dilute. Low
Right.
serum sodium hyponatremia and low serum osmolality, often less than 275 millisem centigrade.
Low and dilute blood.
Look at the urine. It's highly concentrated because the body is desperately holding on to every bit of water thanks to that excess ADH. So you get a high urine osmolality, greater than 100 millisem centigrade, often much higher.
Okay, low blood concentration, high urine concentration.
And another key giveaway is high urine sodium, typically greater than 40 milliequivalents per liter.
Why high sodium in the urine if the blood sodium is low?
Good question. Because the body is volume expanded from retaining water, it tries to excrete some sodium to compensate for the volume, but the overwhelming effect of ADH forces so much water reabsorption that the sodium just gets concentrated in whatever tiny volume of urine is produced.
Ah, okay. That clarifies it. Understanding those opposing labs feels really key.
It is.
And this translates directly into management strategies that are just as polarized, just as opposite.
Completely different playbooks.
For DI, the goal seems pretty straightforward. Replace the massive fluid loss.
That's priority number one. You're meticulously tracking intake and output INOs. You're getting daily weights to monitor fluid status precisely, and you're encouraging oral fluids constantly if the patient can drink. Sometimes IV fluids are needed if they can't keep up.
Okay, and medications. For central DI, it sounds like you just replace what's missing.
Exactly. For central DI, you administer desmopressin, or DDAVP. It's synthetic ADH. It directly replaces the missing hormone signal.
Right. But here's the part that seems tricky. Nephrogenic DI. The kidney isn't listening. What do you do then? Our source mentions diuretics.
Yeah, and this always sounds totally counterintuitive, doesn't it? For nephrogenic DI, where the kidney ignores ADH, you actually often use thiazide diuretics and sometimes NSAIDs like indomethacin.
Hang on. DI means massive water loss. They're already losing tons of fluid, and you give them a diuretic, a water pill. How does that possibly help? Are we like tricking the kidney somehow?
That's actually a great way to think about it. You are kind of tricking the kidney. Thiazides work by blocking sodium and water reabsorption early in the kidney tubule, in the distal convoluted tubule.
Okay.
This causes a very mild state of sodium and volume depletion. Now, because the body senses this slight dehydration upstream, the proximal part of the nephron, the part before the ADH-resistant collecting duct, works much harder to reabsorb salt and water.
So it pulls back more fluid earlier.
Exactly. By the time the fluid reaches the collecting ducts way downstream, the part that's broken and ignoring ADH, there's actually less fluid volume arriving there overall. This forces more passive water reabsorption just due to osmotic gradients and ultimately reduces the massive urine output. It's a really elegant physiological workaround for a broken receptor.
Wow. Okay, that makes sense now. It's about reducing the load on the broken part of the system.
Precisely. And one more thing for DI patients' crucial education point. They're advised to wear a medical ID bracelet, because if they collapse or are found confused, responders need to know immediately about their condition.
Good point. Okay, now let's shift gears completely to SIADH management. If DI is about replacing fluid, SIADH must be about restriction.
Total restriction. The cornerstone of SIADH management hinges on severe fluid restriction.
How severe?
Our sources cite a typical limit of 500 to 600 milliliters in a 24-hour period.
That's incredibly strict. That's barely 2 glasses of water all day.
It is incredibly strict, and it requires huge patient buy-in and education. The nursing staff has to explain the entire procedure and rationale because the patient will feel thirsty, intensely thirsty sometimes, but they absolutely cannot drink beyond that limit.
That sounds psychologically really tough.
It is. And because the risk of neurological catastrophe from that low sodium is so high,
Seizures again.
seizures, coma, immediate seizure precautions are absolutely vital. Padding the bed rails, having suction ready,
And close monitoring.
constant monitoring. The nursing staff needs to check the patient's level of consciousness, their LOC, frequently like every 2 hours, sometimes even more often if the sodium is very low or changing rapidly.
Wow.
And the environment matters too. A quiet, calm room can help manage the anxiety and potential neurological irritability associated with the hyponatremia and the severe restriction.
Okay. What if the sodium is critically low? Is restriction enough then, or do you need to intervene more aggressively?
If the hyponatremia is severe or the patient is symptomatic, like having seizures, then restriction alone isn't enough or fast enough. They may need to cautiously administer hypertonic saline, usually 3% saline.
Hypertonic, meaning much saltier than normal blood.
Exactly. It helps pull water out of the brain cells and raise the serum sodium. But this is a real tightrope walk. You have to infuse it slowly and monitor labs constantly.
Why slowly? Can't you just fix the sodium quickly?
You absolutely cannot correct it too quickly. If you raise the sodium too fast, you risk causing a devastating neurological condition called osmotic demyelination syndrome, or ODS. Central pontine myelinolysis is the classic form. It can cause permanent brain damage. So slow and steady is the rule.
Right, so hypertonic saline, but carefully. Any other medications? Maybe diuretics here too.
Sometimes, yes, a loop diuretic like furosemide might be used, but usually only if the serum sodium is not critically low, say above 125. Its main use here is to increase free water excretion, but you have to be careful because it can also cause sodium loss. It's often given with salt tablets or hypertonic saline in specific situations to manage the fluid volume without letting the sodium drop further or to help raise it gradually. It's complex. Hashtag tag that outro. So if we want to synthesize this whole deep dive, I think the main takeaway is that the crucial distinction really is that mirror image defined by the body's chemistry. DI means dehydration. It means hypernatremia, high blood sodium, and low urine osmolality, meaning dilute urines. Remember? High in dry blood, dilute urine.
Okay.
SIADH is the opposite. It means water retention, water intoxication. It means hyponatremia, low blood sodium, and high urine osmolality, concentrated urine. Low in wet blood, concentrated urine.
High dry versus low wet.
If you can grasp those two opposing columns, serum sodium and urine osmolality flipping, you've really got the core for understanding these ADH regulation disorders.
Yeah, that really clarifies it. You know, what really stands out to me, though, is the sheer opposing difficulty of the patient experience and the management. We're talking about a DI patient who's just pouring out maybe 20 liters of fluid a day, desperately thirsty, begging for water. And their management involves giving them synthetic ADH and encouraging fluids.
Right.
Now, contrast that with the SIADH patient. Their critical, life-saving intervention is that agonizingly strict fluid restriction, 500 to 600 milliliters a day. Imagine. I mean, just try to imagine for yourself the profound mental discipline required to manage that. To live with a condition where every natural instinct to quench your thirst must be actively suppressed, knowing that even a single extra glass of water could potentially push you towards cerebral edema, seizures, neurological collapse.
It's intense.
That really is the tightrope walk of treating SIADH, isn't it?
Yeah.
And it puts the incredibly high stakes of our body's fluid balance into really sharp perspective.
Yeah.
It's not to think about.